let's get into it. So the things we'll cover today are early descriptions, microscopic discovery, inheritance patterns, molecular disease, the journey towards the Sickle Cell Anemia Control Act of 1972, modern perspectives, and current treatments. So this is me. So this is a little bit more about me. As Brian said, I grew up in Houston, Texas. I was very close with my cousins. So you can see the two people in the middle. Those are my cousins, and my sister, who's cheesing on the left, that's her, she's older. And that's me, looking cute with the blue and white stripes. I have several family members that have sickle cell disease. My mother's first child passed away in Nigeria from sickle cell disease when he was a toddler. And my cousin, with the red shirt, he passed away when he was 19 in Houston when he was transitioning from the pediatric world to adulthood due to complications of sickle cell disease. I still have several family members that are still living with sickle cell disease, and they're actually doing well. I have an aunt that's in her 50s, almost 60, who has never had a complication, and she has hemoglobin SS disease. So there are definitely variable levels of severity of sickle cell disease. All right. So sickle cell has always existed. It's not something that Americans discover, that made up or created. This was something that's been described in literature for over 5,000 years in Nigeria and other parts of Africa. In the Igbo tribe, which is a tribe within Nigeria, they used to call children with sickle cell disease the Obanji children. And this means children that come and go. And so the reason, as you can tell by the way the phrase, come and go, these kids didn't live very long. And that's why, because there wasn't any treatments, there weren't any, good antibiotics to treat these children when they did get infections. There are also several descriptions that really are indicative of the symptomatology of sickle cell disease. A gentleman by the name of Felix Kanote Ahulu, who's a Ghanaian researcher, documented some of the prior names that his tribe used to use, even before we understood what sickle cell disease was. And some of these names were just onomatopoeias that were reflective of the pain that people experienced that had sickle cell disease. And so, for those of you who don't know what onomatopoeia is, it's a word that describes what something feels like or something sounds like. So as you can see, some of the words that are being used look painful. And we have a woman here that's in the corner, and she is the oldest living person with sickle cell disease. She's turned 90 last year. Her name is Asiada Onikoyi Laguda, and she is a Yoruba person like myself, like a Nigerian person that speaks the Yoruba language. And so she's doing well. And her advice is to live long with sickle cell disease. You should live a life of moderation. She eats what she wants, she lives a healthy life. So just a case, as we normally do in internal medicine. So we have a 20-year-old intelligent Negro dental student with a past medical history of yaws, nicotine abuse, presenting with 5 weeks of cough, 2 days of fever and chills, and for the past year he's been having some palpitations, shortness of breath, and leg ulcers. He immigrated from the island of Grenada 3 months ago to attend dental school in Chicago. He recently had some leg ulcers that he treated with tincture of iodine, which is a type of antimicrobial agent, and it actually healed very well. His past medical history is significant for when he was 10, he had yaws, which is a tropical Treponema pallidum infection that's not your typical like syphilis, sexually transmitted disease, but more of like a skin-to-skin contact that many children had in the olden days in tropical areas. When he was 17, he had a purulent otitis media and externa that lasted about 6 months, but it eventually resolved. And so he actually hasn't had any symptoms of this since then. He's 20 now. He has no surgeries. His family is healthy. His mother's healthy. His father died of an accident several years ago, and he has 3 healthy siblings. And the social history is as described. He is from the island of Grenada, and he reports that he does smoke excessively. So you come in the room and notice on exam on your vitals that your temperature is elevated at 101. His pulse is 80, and he's not tachypneic. You don't check a blood pressure at this time. Generally, in your notes, you describe him as having typical Negro faces, curly hair, and intelligent. For HEMT, you notice he has stellar icterus, mucous membrane, nasal discharge, and pharyngeal erythema. His ears look normal. He has diffuse lymphadenopathy, none of which is tender. His respiratory exam shows some hair expansion, some scattered moist rails, and some dullness at the bases of the lung. Cardiovascular, you propose his cardiac borders, and you notice that he has some slight enlargement to the left and a little bit of slight dullness on the right as well. He has a soft systolic murmur at the base of the heart. His abdomen is non-tender, and you can't palpate his liver and spleen. Skin shows multiple scars on the abdomen and thighs and legs. GU exam is normal, and his neuro exam just shows some sluggish reflexes, but otherwise the neuro exam is completely normal. So you notice, he's febrile, and he's looking, kind of bad. He's pale, and he has some scleroicterus. So you get some labs on him. So you get a urine, and so the only thing you really find is some granular hyaline cast. He has a little bit of bile in the urine, but he has no hematuria. You get a sputum sample because you want to make sure he didn't have tuberculosis. He's a recent immigrant, so you notice there's no tuberculous bacilli on your sputum stain. You get a blood sample, and you notice that he has 2.4 million red blood cells, which is much lower than the 4 to 5 that you would expect. And his hemoglobin is 40%, which in percentage of hemoglobin, 100% would be normal. So it's actually significantly decreased. He has 40,000 white blood cells, 72% PMNs, 15% lymphs, 7% monos, and an eosinophilia of 5%. And you notice also multiple nucleated cells with varying in size and shape and color. So, you notice this blood sample and you're like, you know what, we should probably get a smear on it. So you get a smear and you're like, what in the world is this? Like, I've never seen anything like this. Like, normally, the microscope is a popular modality now, and I've gotten tons of peripheral smears on a ton of people, and I've never seen anything like this in my life. Why do these cells look so long? And they look like farming equipment. They look like a sickle, like something I would use in my backyard or something. And so, you describe it as, peculiar elongated forms of red corpuscles. So this is this patient that was described as the first patient that was ever described having sickle cell disease. His name is Walter Clement Noel, and he's the immigrant from the island of Grenada. He presented to a local physician. He's in school just like some of you medical students. And imagine you're sick and you go to your local physician and you say, hey, I'm not feeling well. The name of the physician was James Herrick, who actually is a cardiologist primarily by training, but at that time in 1900s, 1910, people practiced everything. So Dr. James Herrick was like, it's kind of like Samit over here. I just care about the heart. I'm not really interested in it. I'm just kidding. So he kind of, he's a little less interested in this case. And he says, you know what, resident Ernest Irons, I want you to take this case, work this guy up, see what you come up with. So you have Ernest Irons in the corner with the gray hair on the side, and this is his attending here, Dr. James Herrick, on this side. So Ernest Irons, being a vigorous, resident and wanting to be thorough, he gets this mirror, and he's the one that first recognized those abnormal cells. So they admit the patient, they give him rest, nourishing food, and syrup of the iodine of iron, which is a type of broad-spectrum antibiotic. They give him thymol, which is also another type of antimicrobial agent, and they primarily give him this because they're thinking that he has some kind of parasitic infection. They know it's eosinophilia, he's recently from Grenada, and they're actually checking him for eggs and different things like that, but they're not finding it. But they still put him on empiric, the vacanzosin of their day. And so they repeat his blood count 4 days later. And notice as the white count has come down. So our broad-spectrum antibiotics, they work well. And his red blood cell count starts to creep up a little bit. So instead of hemoglobin of 40%, he now has a hemoglobin of 50%. His fever and neuralgia and lymphadenopathy have all improved. And he's discharged home after admission for 4 weeks. And so it's not, your typical 5-day stay as we would have here, but he was there for quite a while. And I believe some of this was probably because this is a new disease. And Dr. Herrick and Ernest Irons were actually very excited and very curious as to what was going on with the gentleman. So just like our current patients, he had multiple readmissions after that point. But most of these readmissions were actually managed by the resident, Ernest Irons. He actually followed this guy for throughout his dental school. And Dr. Herrick actually only met him twice. So, Walter Clement actually completed dental school successfully. He went back to Grenada after he finished, and he opened up a dental practice there. However, he died of complications of sickle cell disease when he was 30. But, he lived a pretty, healthy, successful life. So, Dr. James B. Herrick, as the attending here, he publishes a paper, and as you can see, Dr. Ernest Irons, the resident, his name is not quite on the paper. And so, back then, it wasn't really standard practice to put the resident's name on the paper. But, in the paper, he kind of describes that, Ernest Irons took good care of him, and he used Ernest Irons' notes in his very meticulous documentation in order to write this paper. And the descriptions that I described in the H&P and the Negro faces, these are all the things that actually were written in Dr. Herrick's paper, and that was kind of typical of early 1900s. And so that's it. So just to kind of give you some background, this was very significant. And I was like, wow, you have an African American gentleman that's coming into a white man's clinic in 1910. And this was, remember, Emancipation Proclamation was signed 1863, and this is the middle of Jim Crow. You know, this Jim Crow, and this black man is coming in. You know, so I thought the relationship that Ernest Iron, a resident, had with this African American patient was very significant. He took very good care. He wrote good notes, and he really would make sure that this gentleman did well despite of the color and despite of the fact that Jim Crow is prominent at this time. The other thing is that, a lot of African Americans, because of Jim Crow, they weren't really getting adequate care for the majority of African Americans. And so at this time, a lot of entrepreneurs or freedmen from the North started a lot of medical schools and hospitals in order to meet the need of African American patients at that time. And one of the first medical schools in the South was Meharry. And so as you can see in the corner, you can't really see it very well because of all the food, but these are some of the African American medical students that are studying at the time. Also, there were charity hospitals that were built for people that couldn't afford medical care at the time. And so there was some controversy with that because some of these poor patients were seen as medical commodities to a lot of the bigger, white institutions. And so they were worried, like, am I just a medical commodity or am I a human being, that's more than just my disease? And so, but they still benefited from the medical care they were getting at the time. Also, the rise of the public health infrastructure was rising, considering that infectious disease was prevalent, and the biggest cause of death in the early 1900s was still infectious disease rather than chronic disease, as we kind of see now. So more and more papers were being published, and more case studies were being documented of this, sickling, abnormal sickling of cells. And so this actually really helped people to come up with a name for this disease, and they called it sickle cell anemia. And so this really emphasizes the point of writing case reports, because had not, people all over the country written papers, they wouldn't have known, what this disease was and how and where to go from here. So it was really excellent. So two gentlemen by the name of Hahn and Gillespie actually discovered that when a patient, the red blood cell of a patient with sickle cell disease is deprived of oxygen, that is when the sickling occurs. And so that was a big, finding, and it helped kind of lead the way to figuring out how sickle cell disease even happened. So they also looked at relatives of these patients that had sickle cell anemia, and they realized that when they take their red blood cells, their cells also sickle as well. And so they were like, well, these people are asymptomatic, but they're still demonstrating sickling of their cells. So they called this sickle trait because there wasn't a true disease or a true anemia. So the rise of genetics. So in 1949, 2 articles were published. And there were 2 parts of the world. So we have, in Africa, there is a military physician by the name of Colonel E.B. He publishes a paper about the genetics of sickle cell disease, and another gentleman by the name of James B. Neal in Michigan that publishes his paper in the American Journal of Science. So some people say that these 2 actually collaborated in their findings, but most people attribute James B. Neal for the genetic discovery. So prior to this paper being published, it was believed that there was just one dominant gene that caused sickle cell disease. That everybody, whether you had the trait or the sickle cell anemia, you all had that one gene, and that was just variable expressivity of that particular gene. They didn't believe in heterozygotes and homozygotes. But these physicians came out and said, you know what? I think it's different. And they started studying the parents of these patients that had sickle cell anemia and realizing that they are more likely to have the trait. And so after much studying, they realized that they had a hypothesis that there was a heterozygote and homozygote difference. And heterozygote meaning that they are carriers of the trait, they have sickle cell trait, but they don't have true disease. And homozygote meaning that they have 2 copies of the disease and end up having true disease because of that. So 1950s, more and more discoveries are happening, and they realize that patients that are heterozygotes or carriers or have the trait, these are all the same interchangeable words that we use, they realize that these patients that are heterozygotes, they actually protected against malaria. And they were like, oh wow, so sickle cell disease is not just a Negro disease. This is a disease probably that's more tropical, and we can trace its origins to more tropical climates. And so they realized that, Indian people had this, people from Saudi Arabia had this, so this was like more of a regional kind of a finding, and that it was actually protective to be a heterozygote while you live in these areas. So that was actually a phenomenal finding. It actually led to kind of elucidate more of the genetic component of sickle cell disease. So people look at sickle cell disease as the first molecular disease. This kind of opened the doors for molecular medicine. And one gentleman by the name of Linus Pauling, who's very popular, he's a Nobel Prize winner in chemistry, excellent fellow, said, I think sickle cell disease is caused by flaw in hemoglobin. It's not just the red blood cell itself that's messed up, there's a hemoglobin that's abnormal. And you realize that patients with sickle cell disease had a variable electrophoretic property than people that had normal hemoglobin. And he didn't know quite how that worked, but he knew that they had different types of amino acids. He just didn't know how that was different. Also, he realized that abnormal hemoglobin is what polymerizes when it's deprived of oxygen, and that forms the sickling of the cell. So this was a phenomenal finding, and as you can see, Linus Pauling is in the corner, and they made a stamp after him, and he has sickle cells all behind him in the picture and everything, because he's a phenomenal guy. So maybe one day you guys will get one of that. And so we have Vernon Ingram, who comes behind Linus Pauling and says, you know what, I think I can figure this out. And he says, I think it's the change from glutamic acid, amino acid, to valine. And he's the one that actually described that. And so it's kind of a collaborative effort. And it comes a few years just after Linus Pauling, and he makes that discovery. So at this point, we know what causes sickle cell disease. We know the genetic, we know that, the DNA sequence change, we know the amino acid change, we know that it's the hemoglobin, we know what causes sickle cell disease. This is 1956, we know. No question about it. But we haven't answered the question of what are we going to do about it. These patients are still suffering. We got, our scientific fix, and we know, what's going on, but how are we going to treat them? So another wonderful gentleman by the name of Lemuel Diggs that is in Tennessee says, I really think this disease is pretty cool. This is an obscure disease. I've never heard of this before. It's pretty unique. So I want to study it more. And he's a pathologist, or what you would call present-day hematopathologist, meaning that he likes hematology. He's really big in community blood banking, and he's really just big in blood disorders, period. He's also doing a lot of autopsies on these patients with sickle cell disease and learning a lot as well. So he says, I want to create a whole medical center dedicated to just studying obscure diseases that I've never heard before. So he opens up the University of Tennessee Medical Center with the help of some other people. Also in 1958, he was one of the people that opened up one of the first comprehensive sickle cell centers. He says, this patient population needs better care. And with the help of a lot of black donors at the time and a lot of local philanthropists in Memphis, he opens the center in Memphis, where Vanderbilt area is. So this is an exciting time for the treatment of sickle cell disease. So, I always like to go to context, because I like to think of when are these things happening, and why is this so significant? You have a white gentleman that's saying, I want to open a comprehensive sickle cell center for all these black people, and because primarily the people with sickle cell disease were black in America. So this was pretty incredible at the time, and some of the people that were donating were African American donors and entrepreneurs. So this was incredible. And so sickle cell disease for the black community at this time, because you remember, this is 1950s going into 1960s, where the civil rights movement was huge. But black people were still suffering. They were being beaten, they were being still hung, they were being hosed, and Martin Luther King was out there doing his work, and people were still being persecuted at the time for wanting to get civil rights. So the Black Panther Party came out and were like, you know what? Our community, we're not getting adequate care. Whites are getting theirs in their facilities, but, we're segregated, and our black facilities are not getting what they need. So, we're going to start a facility to help our own people. And so, one of the big models of the Black Panther Party was, all power to the people. So if the government's not helping, we're going to go out there and we're going to do it. Just like Lemuel Diggs said, you know what? No one's doing this. I'm going to get a whole bunch of donors. I'm going to open up a facility. So this was huge at the time. And, most people knew the Black Panthers as just people that were rebel rousers or whatever, but they were doing a lot for the community at the time. So they opened up the People's Free Medical Centers, and they also were big people doing sickle cell anemia testing at the time. So at this time, 1960s going to 1970s, sickle cell disease was known as a neglected disease still. Even with all the noise, the Black Panther Party was making and Lemuel Diggs was making and trying to get people to, kind of improve the care of this population, they feel like it still didn't get enough attention. But with enough noise, they actually got President Nixon in 1972 to sign an act called the Sickle Cell Anemia Control Act. And what it did was provide a lot of funds for research in community clinics and genetic counseling. It also provided some mandatory screening for children, but this is a little controversial because some of the screening was actually done without parental consent. At this time, they weren't thinking about a lot of the ethics at the time of things, but that kind of caused a little bit of problems. The other problems that this bill caused, even though it provided a lot of funding, is that it caused a lot of restrictions in patients in the Air Force, especially patients with sickle cell trait. And because at the time it wasn't quite clear what kind of disease process people with the trait had. Some people thought it didn't have any problems, and some people noticed that some of these patients with the trait still have splenic infarctions, they still have renal capillary necrosis, they still have sudden death. And so they were like, should we be putting people with the trait in the air? And so they restricted a lot of people that had the trait, and especially now that testing was a little bit more aggressive, they would know who had the trait married or not. Also, but one of the big positive things that this led to the newborn screening. So there was a meeting by the NIH and several other organizations in 1986 that said, you know what, we should make sickle cell disease a routine part of the newborn screening, so we can all just know who has it and treat it early on. And so later on, they came to make this a mandatory part of newborn screening. So, like I said, this was concerning to the black population at the time because, Nixon and some of these people were using terms like eradication. And you have to remember, like, black people were predicted to have passed or to become extinct after Emancipation Proclamation was signed. A lot of the slave owners at that time, during slavery, were the ones that primarily provided the health care for African Americans. And so they called it planter paternalism, meaning that the slave owner made sure their people were healthy in order so they could do work and make their money. So they said, you know what, this population is going to become extinct once they're freed. And so a lot of black people still living in the light of that were like, are they trying to eradicate us as, people, so in order to destroy this disease? Or so there was a lot of fear in that, in his terminology. Also, children were still dying. The highest mortality rate was still in children. And a lot of it too, there's still a lot of infectious disease going on at that time as well. But this was the rise of a lot of antibiotics coming out, so that actually was helping to allow children to live a little bit longer. Yeah, and you'll see later on that penicillin became a huge, medication used as prophylaxis for children. One big outbreak thing that came out in the 1970s was the Tuskegee syphilis scandal that really shook the black community because they're seeing, these people, like, we put our trust into the healthcare system, and now they're running a 40-year experiment on black men. And how can I trust the medical community if they're running a 40-year experiment on black men and not telling them what they're doing and withholding care from them? You remember, antibiotics came out this time. So 40 years, they withheld penicillin from these gentlemen, and even to the point where some of them, when they were entering the military and were getting tested and were getting ready to get antibiotics, they would say, no, do not give them penicillin because we want to know what happens until death. So if you're in this experiment, you literally were deprived of antibiotics even though they had it. And so this was really, and the New York Times paper came out in the 70s, the whistleblower put the article out. And so this was a big deal. So, in light of that, one of the other things that came about in the 1970s was the way that we think about sickle cell disease changed dramatically. And I think part of this was because of the war on drugs. You have to remember, like in 1968, Nixon was the Vietnam War was prominent at this time, and a lot of blacks and like Martin Luther King and hippies, a lot of people, they opposed the Vietnam War, and so Nixon actually had a plan to kind of criminalize blacks and hippies, and so what he developed a plan, which his advisor later exposed in the 90s, saying that Nixon actually had a plan to make hippies associated with marijuana and to make blacks associated with heroin, and to criminalize it and put them in jail and destroy their communities, and also put it on the evening news so that people can associate blacks with heroin. And so, the sickle cell patient population were casualties of this propaganda that was being put out around this time. And so people looked at patients with sickle cell disease as drug seekers. And we're still kind of living in the light of that today, where people look at patients with sickle cell disease and they associate them with the drug seekers that are coming in, to get actually heroin. And these patients really just need pain relief. That's part of the disease process. All right. I thought this part was kind of funny to me. This is the largest study in sickle cell disease. It's called the Cooperative Study of Sickle Cell Disease, and it was initiated by the NIH and the National Heart, Lung, and Blood Association. It was a prospective study looking at the natural history of sickle cell disease. I found this funny because it was similar to the Tuskegee experiment, but it was ethical. It was an ethical version of it, but they were able to get 4,000 people to sign up for the study. That's a lot of patients, to sign up for that. And this was done across 23 institutions in the United States. So this was huge. And all it was just looking at the process of sickle cell disease so we can understand it better. What is acute chest? What is dactylitis? Like, what are all these things? And this study actually really helped us to understand how sickle cell disease works. So this was incredible, and many other studies were done based on this study, just like the Framingham study as well. So at this time, no treatments were available until hydroxyurea came along. Hydroxyurea is huge. We're always pushing hydroxyurea because it's the only disease-modifying drug in sickle cell disease that we have currently FDA approved. There's some other in the work, but nothing's FDA approved yet. So hydroxyurea has always existed. It existed in the 1800s. A German developed it. Dressler and Stein developed it, but no one was really using it. So until like almost 100 years later, the FDA approves it and says, you know what, we can use hydroxyurea to treat CML. We can use it to treat psoriasis. We can use it to treat polycythemia vera. They also, a few years after that, they discover patients that have higher levels of hemoglobin F or fetal hemoglobin have less severe disease. Like, this is incredible. So they were like, you know, if we could find a way to increase fetal hemoglobin in these patients, they can have less severe disease and less hospitalizations. So in 1984, they discovered that hydroxyurea increases fetal hemoglobin in people. So they're like, oh yes. So hydroxyurea. So they published a paper called the Multi-Center Study on Hydroxyurea, and this was published in the New England Journal of Medicine in 1995 that showed that hydroxyurea can reduce sickle cell crises by 50%. It reduces hospitalizations, it reduces acute chest syndrome, and they discovered that hydroxyurea is like key. And so they made it FDA approved by 1998. But they were still kind of skeptical of using hydroxyurea in little children, so they started the baby hug trial. And so this is just a study of hydroxyurea in children. There's a lot of fun names, just like the heart studies. You know, hematologists have fun names too. So that lasted from 2003 to 2009, and it showed the same results. And they expected that children, when they were given hydroxyurea, would have more infections, but they found that even though hydroxyurea causes myelosuppression, it does not cause more infections. And so this was incredible because they have reduced hospitalization, they have reduced dactylitis, they have reduced need for blood transfusion. So this is like, you know, blood sparing kind of a drug as well. So this was huge. But still, people didn't understand how hydroxyurea works. So, you know, a lot of patients are kind of skeptical. They're like, y'all giving me a drug, I don't even know how it works. And so that's kind of, you know, one of the downsides to hydroxyurea. But we know it does work by increasing fetal hemoglobin, just not really how. Also, some people think that aside from hydroxyurea increasing fetal hemoglobin, it works because it reduces the neutrophils. So one of the side effects, you would say, is like myelosuppression. Some people think sickling, one of the components that causes sickling is more of an inflammatory response. So by suppressing that, you can have less exacerbations. The other thing is that they think hydroxyurea makes red cells less sticky, so you have less vaso-occlusion as well. So there's a lot of theories out there, but no one really knows for sure. So hydroxyurea, so some people think that the hydroxyurea causes decreased polymerization of the hemoglobin. So if you can see in this picture here that patients that are untreated have more polymerization of their hemoglobin that causes occlusion here, versus patients that have hydroxyurea and that have increased hemoglobin F have less polymerization, have good, nice and clean flow. That was published in the New England Journal. So, you know, we still have a few other therapies, like I mentioned before, antibiotics, because remember, you know, patients with sickle cell disease are autosplenectomized, so they're at risk for diseases from encapsulated organisms. So you put them on penicillin prophylaxis, recommendations up to age 5, and some people will still continue in after that. Vaccination, of course. And chronic prophylactic therapy is key as well for stroke prevention, primary and secondary stroke prevention in patients with sickle cell disease. Because remember, they have vaso-occlusion, and so that can cause silent strokes that you may actually never see, and overt strokes as well. So 1998 was another landmark trial called the STOP trial that showed that there was a 92% relative risk reduction in stroke as primary transfusions are used as primary prophylaxis, meaning that you get transcranial Dopplers and screen them to see what is the velocity of flow in the brain as well. So they noticed that patients that have velocities greater than 200 centimeters per second, if they're put on chronic transfusion protocol, like about every month or so, they have a decreased risk of stroke, significantly decreased. So this was like, we need to start doing this. We need to start doing transcranial Dopplers, and we need to start giving transfusions. So they were trying to see, like, okay, we're giving a lot of blood to these patients, so that was kind of the standard at the time, and still the standard now. But they're like, there's a lot of iron overload with all these transfusions. Like, we can't just keep doing this forever. So a lot of people were trying to come up with trials to say, maybe if we transition these people from chronic blood transfusion to hydroxyurea, maybe that, you know, we can spare them from getting so many blood transfusions and reduce iron overload. Because iron overload is also associated with increased mortality as well. So it has like has bad side effects as well. So they did the switch trial in 2012 that showed that patients that switch from chronic transfusion, this is secondary, patients that have already had a stroke, that switch from chronic transfusion to hydroxyurea had a 10% increased risk of stroke. So they were like, that's not acceptable. And so it's still, the standard is blood transfusion. They did the twitch trial in 2014, it's not the switch, that looked at transfusions as primary prophylaxis just in people that have high elevated velocities, flow velocities. And they found that actually it's non-inferior. Hydroxyurea is non-inferior to chronic transfusions, but the trial was stopped early, and so no one really knows what are the long-term consequences of stopping transfusions, so we still do it. And so a lot of work still needs to be done, that's only 2 years ago. So bone marrow is the most expensive use of Medicaid, which means that if they're the most expensive users of Medicaid, that's a disease you probably should focus on and to minimize the use as well. And that would be a way to save literally millions of dollars. Like Hopkins had one center. They saved $1.9 million with one center. And we're talking about making 3 of them in upstate New York and 5 down. And like I said, like we take care of a large piece of the population in the United States. And so it's estimated it's $15,000 per patient per year. That's the cost. Remember, we're at 300 patients, $15,000 per patient per year. That's a lot of money that we're spending on hospitalizations and ED visits. So, if you can cut that down and use a day hospital, which, the only thing we're asking is $3 million per year for 5 years for the whole state. That's a significant, cost saving. Any other questions? Yes?
So in terms of hydroxyurea, can one make the case that any and all patients with sickle cell disease should be on hydroxyurea, regardless of the number of pain crises they have every year?
I would say no.
No?
I would say no, because hydroxyurea it's fairly benign, has very minimal side effects, I would say. But you still have the risk of myelosuppression. You still have the risk of reducing your sperm counts as well in males. Like there are some side effects of hydroxyurea, not big ones. Most people tolerate just fine. It can cause a little GI upset. However, the recommendation is 3. You have to have at least 3 exacerbations in 12 months, or having acute chest syndrome. And you have to look. The 90-year-old woman I showed you, the oldest living survivor with sickle cell disease. My cousin's hematologist. Her father has sickle cell disease. He's 80. So people tell you the life expectancy now is like in the 50s. They expect most average people to live until their 50s, but there's people living long and healthy lives that you may look at Tiki Barber. Nobody knew Tiki Barber has sickle cell disease. So it's variable. It's variable.
If there's any research being done on potential new fancy treatments for sickle cell?
There's like the BCL11A type stuff, but I know my cousin's hematologist came out with something, but I didn't get the details of it. But there are a lot of other new fancy things, coming out. Not quite sure exactly the details of them, but people are trying. It's just that you're weighing the side effects and risk, and nothing is FDA approved yet. So we shall see. Gene therapy, I think, is coming. It's on the rise. It's a genetic disease. Why not? Just like or can be in CF. Modifying the genetic in order to reduce the disease severity. Anything else? Comments? Questions? Hugs? It's my husband over here. If you want to meet him, he decided to show up. Televised. Love you, boo. All right, you guys have a